afternoon, everyone. I'm Brooke Kroger, and thank you so much for coming. It's my pleasure to introduce our two very distinguished speakers today who are going to be, after short presentations, in conversation with each other about these all-important issues. Elisabeth Rosenthal, who we call Libby, is an award-winning New York Times senior writer who trained at Harvard and what is now New York Presbyterian as a medical doctor, which she also practiced in emergency room medicine. Her 2-year-long series for the Times, which most of you must have seen, on healthcare costs called Paying Till It Hurts, has inspired her current book project, which we should expect to see in publication next year. The beats she has covered for the Times include healthcare, international environment, and in addition, there was a 6-year stint as a foreign correspondent in China. She received her B.A. from Stanford, holds an M.A. in English literature from Cambridge, where she was a Marshall Scholar, a true Renaissance character, and a good friend. Robert Chaloner, who is a name that's, I'm sure, familiar to all of you, has been the president and CEO of Southampton Hospital since 2006, so that's a decade, where he has been actively engaged in stabilizing and rebuilding the hospital's financial and operating performance, as well as reestablishing. He also chairs the CEO Council for the East End Health Alliance and the Long Island Regional Health Information Organization. Bob is a graduate of Dartmouth with an MS and M.P.H. from Columbia and an M.B.A. from my institution, NYU. Welcome to both of you, and Libby will start.
I'm going to start with a video. It's a very short comparison of this gentleman, Mike Chopin, who had his hip replaced in Belgium, and the other character you'll see is named Susan Foley. She's a lawyer in Oakland, California, who had her hip replaced at Mills Peninsula Hospital, and I'll let them do the talking.
I needed a hip replacement, and I started looking into what it cost to have it done.
It came to $112,000, $112,317 total charges for the hospital.
I'd heard about having surgery overseas. Basically, the price was $13,660 for everything. The surgery, the rehab, the flight over and back, 2 people, crutches, medication to take home with me, everything.
This is not the prosthetic. This is not the anesthesiologist. This is not, anybody who actually did anything. This is just the hospital bill.
Total cost of hip surgery in Belgium, including everything, cost just about $600 to $700 more than the wholesale cost of just the prosthetic device in the United States.
The good thing about my knee surgery was getting my mobility back and getting my life back. And it enabled me to start horseback riding at 68, 66, which most people don't start horseback riding at 66. And I couldn't be doing that without the joint replacement.
I bought a new board, new snowboard, new boots, all this stuff, because I'd given it up years before because I couldn't, and started riding again. I was pretty cautious for the first year just because I was scared of falling. But this past year, I taught 26 days on the mountain. I mean, I'm stronger than I've been in a decade.
Okay, so we've seen 2 joint replacements, one in Belgium, one in the U.S. I should say both of these people had their joints replaced when they were pre-Medicare age. Mike Chopin was insured at the time, but because his hip trouble was due to an old sailing accident, his insurer considered it a pre-existing condition, so said he had to pay out of pocket. So I'm going to ask everyone, because I like to start this. I mean, how many of you have opened a bill or seen an explanation of benefits statement and looked at it and thought, what on earth is that about? How many people have had that experience? How did it get that expensive? Why are there 5 different bills? Why is the bill 100 pages long? There are so many questions, and you can't get real answers. So that's what I wanted to answer for myself and for my readers when I set out to do this New York Times series, Paying Till It Hurts. and why I had to keep going with the book, because I didn't really get to the bottom of it. And this, for me, was just a little bit about my background. It was a pretty deeply personal mission. My dad was a doctor. He was a hematologist. I trained as a physician, you heard, and worked in an ER, and had come to the Times to cover the Clinton health reform effort, and thought when that was succeeded, I would just go back to being a doctor. And of course, here I am 20 years later talking about the same things. And what motivated me was I had spent 10 years as a foreign correspondent for the Times, where I experienced healthcare in other countries. So I broke my arm in Stockholm, went to the best hospital, the best orthopedist on fantastic insurance. He saw me, sent me next door for an x-ray, splinted the arm, and then apologized for having to charge me $400, which was the private rate. Likewise, I got a cut above my eyebrow in Rome, went to Gemelli Hospital, the Pope's hospital, had it stitched up, and was out of there with a €110 bill, so $125. And when I came back to the US, and I'm going to make this really fast, I was 50, and I needed that thing that 50-year-olds need, which is a colonoscopy, right? So it was my first reintroduction to American healthcare after 10 years away. And I wanted to do it in network. I found an in-network hospital that had a colonoscopy clinic. It was partly where I'd trained. And I went in and I thought it was a little funny because I was brought there and I was getting like a surgical bonnet and being put in a gown, and my clothes were taken. I got a hospital wristband, I got an IV, and I was wheeled into what I knew was an operating room because I'd trained there. Like, why are all these nurses and anesthesiologists running around? And anyway, my concern evaporated with my propofol, and I was happy, and I woke up, and I got the good news that I had a clean colon, which was great, and not another colonoscopy for 10 years. And I didn't really think much of it until I got a bill and an explanation of benefits statement about a month later, which showed that that hospital had billed $12,000 for my screening colonoscopy, and my insurer, on my behalf, had bargained it down to about $9,500. And my payment was zero. I have really good insurance. So I guess most people would have been happy, but I was really upset because I thought, in a world where everyone is paying $10,000 for a screening colonoscopy, there's a lot of choices we're making that don't give healthcare, the kind of healthcare that most people need and that I want. So anyway, I decided to set out on this series, Paying Till It Hurts. Each one focused on a particular patient and how their medical bills added up. The first one, Now You Know Why, was about screening colonoscopy. And I put out calls on social media through a wide variety of forums, comments on the New York Times website, and also on Twitter. And I said, anyone had a screening colonoscopy recently who'd like to tell me about their costs? And there was a wonderful woman named Deirdre Yapalater who was on Long Island, who was having a screening who had just had one, who was on her lunch break and tweeted me, yeah, I'd like to tell you about mine. So she became the topic of the first story. What I learned, and we've talked about it a little before, is that what's driven up the cost? Why did my screening colonoscopy cost so much? It's because maybe 20 years ago, and I know there are some gastroenterologists in the room, some of this would have been done in the office in a much simpler setting. Then over time, because insurers are always trying to push back, they push down the reimbursement rates for doctors, and the more entrepreneurial doctors say, okay, we're going to open a colonoscopy center, because if you open a center, you can charge facility fees. So the place where Ms. Yapalater went for her colonoscopy, if you get out of the elevator and you walk to the left, it's the doctor's office where she'd had her first colonoscopy 10 years before. If you walk to the right, it's a surgery center wholly owned by the physicians in that practice. So that became a big cost. The other huge cost on our bill, more than the gastroenterologist, was the anesthesiologist, who got twice what the doctor got. So again, that's not the way we want to have our medical care delivered. Again, just very quickly, we went in because we dealt with older people. We dealt with people having pregnancies next. What I learned there is when I had my kids, everything was all included except the TV in your room. Now it's billed item by item. So you want a ball, to ease your labor, to roll on, that's a separate item. The epidural is separate. The bathtub, if you want to have labor there, is separate. My favorite doctor story is there was a family practitioner who tried to save money on her third pregnancy. She said, I'm going to have my son stay with me. She came there about an hour before she delivered, and she had her own Motrin, her own heating pad, and guess what? Isaac stayed with her in her room, and she was charged a rooming-in fee that was exactly the same as she would have been charged in the newborn nursery. So again, we want to talk about all the ways that healthcare has become so expensive for patients. And I think some of the issue is when hospitals talk to insurers and talk to pharmaceutical makers, often the patients are not part of the equation. And I think it's time for patients to be far more active in expressing their needs, because a lot of people are stuck with bills that they can't afford. So thank you, and I look forward to talking more about this with you all.
Can you hear me? Yeah, okay, great. As the hospital administrator sending out all of those bills, I'm a little afraid of getting something thrown at me. I started in 1982 was the first time I worked in a hospital, at Lenox Hill Hospital, and spent about the first decade of my career at Lenox Hill as a junior administrator, sort of working my way up, and have watched healthcare and healthcare finances and billing in this country ever since then. And if you go back about 10, 12 years ago, Google Money magazine, there was an article about the $35,000 hip and other medical oddities. And it was an article very, very similar to the discussion we just heard about the high cost of hip surgery and the variation in hip surgery costs around the country. I knew the article because I was one of the 2 CEOs they selected for it, and I tried to get my kids to get impressed with the fact I was in Money magazine. All they thought was I was standing in front of a hyperthermia chamber and hyperbaric chamber, and kept focusing on what is that machine I'm trying to crawl out of. I would like to say the situation's gotten better over that last decade, and it hasn't. Costs have continued to escalate. The bills are frightening. I deal with this issue every day. And frankly, I try to understand why the costs are the way they are, and it's very different from other countries. I've traveled around and I've looked at the experience in other countries as well, and I can tell you that what we are sending out in terms of bills are frightening to most of our patients. Most of our patients get these bills, the explanation of benefits, and don't understand why the charges are as high as they are. Frankly, all of the explanation that frequently comes out of the mouths of people like me just sound like excuses, and I can't say that there's a lot of rational explanation other than history built into the way that we charge things in this country. I will say that there are a couple of factors that I think are underlying the situation that we have. Number one, the system in terms of how we bill, how we collect, and how we get health care paid for is probably the most, and I would wager, the most inefficient system in the world. We have several hundred payment plans that we are trying to bill for. I have a staff of about 1,100 people. 10% of them are in one way associated with collecting charges and billing. And we bring in consultants with regularity trying to help us understand how to bill, charge, and collect. And my experience at our little hospital is not unusual. The entire payment system is based on a structure where every single item is charged, fed into a payment mechanism, bill is generated, and a price is negotiated. Those bills that most people get, they don't pay. Their insurance companies are paying them on their behalf at a negotiated rate that is significantly less, but that initial billing process is still very, very frightening. The system is convoluted to the point where it's almost unintelligible, and I'm not going to try and make excuses for it. I'm only going to say, as an administrator watching it from the inside out, I think it needs to be fixed. I don't think many of the changes we've made over the last couple of years have significantly improved the billing structure. Yes, we see more people insured today, and I think that that's a good thing. But the basic billing system is still fundamentally based on this convoluted structure where every piece of the business is billed, aggregated separately, and charged. And the rates are a game, essentially, between the providers and the insurers trying to maximize the payment. There is no underlying logic in terms of anything in terms of the price. It's a negotiation, every hospital, every doctor, every provider trying to set a rate. The insurers obviously trying to minimize that rate, the hospitals trying to maximize that rate, and the doctors trying to maximize that rate. And we end up with this mess. I try to understand it in terms of some of the fundamental differences in our healthcare system, and there are some differences. We're a little more heterogeneous society than some of the countries in Europe. But there are certain things that are very similar. I can't argue that the quality is that significantly better, unfortunately, in the United States than it is in some of the countries in Europe. And frankly, in Europe, they do a better job of covering a broader array of the population than I think that we do in this country. We do talk about issues around access and the fact that we want access. Americans have a set a high premium on they want it when they want it. And there are some differences in this country in terms of making those services available. And that access does drive up the cost. Out here we keep an emergency room open 365 days a year, 7 days a year. In the winter, I wish I could shrink that emergency room. But I can't. I have to keep it open 24 hours a day. And it's open, fully staffed for any emergency that may walk through the door in the dead of winter. That takes a lot of people and a lot of technology, and that does drive up our costs considerably. So that access, and I think the fact that the American system is so accessible is a major reason why our costs are so high. I think our billing system is a factor in terms of driving up our costs. I think our medical education system is a reason why we're seeing the costs go up. I'm trying to recruit young doctors to this community. The young doctors are earning salaries in primary care somewhere between $150,000 and $200,000. Sounds like a great salary. It's not when you're trying to buy a home in the Hamptons. Nor is it when you're coming out of school with $400,000 in debt for medical school and college. And these young people have to make a living. They are starting their careers with a mortgage. And we are paying more than many of the countries in Europe, but we're not saddling our young medical students with the debt that we're seeing we are saddling them with much more debt than many of the countries in Europe. I think that that's a factor. I do think that beyond the hospitals and the healthcare, I can tell you that the suppliers are another factor driving up the cost. The cost of the medication, we pay more in this country for drugs than other parts of the world. We pay more for medical supplies. It's very difficult to buy things in healthcare at a discount because of the way that we purchase supplies. And finally, I think that there are other factors, including the level of fragmentation. And if you look at that in most countries in Europe, you do get one bill. And you bill one payer, you get one bill, and that bill is all inclusive. Our model is every doctor in the hospital is billing separately for the services that we're providing. Every provider out in the community, whether it's a nursing home or a home health care agency, is billing separately. And all of these providers billing separately is leading to fragmentation that I think is also a major factor driving up the healthcare exposure. System doesn't work. I'm not going to defend it. I know it from the inside out. I'm sorry, quite frankly, for what we're doing in terms of our billing, and I wish little Southampton Hospital had the ability to turn the system around and fix it. But I unfortunately think it's a much broader systematic issue that needs to be dealt with on a bigger societal level. And I know I'm out of time. So. Don't break anything.
Yeah. So we're going to chat.
Exactly.
Okay. I guess I'll start, since I'm the journalist. I feel like there are a lot of countries around the world, and some of them have more socialized systems. Oh, did my mic get turned off? Can you hear me now? I can just talk loudly. More. What? I think I need someone who knows what to do. Okay. I'll just, if I yell, can you hear me until he comes back? Okay. You know, there are a lot of different systems around the world. Some are socialized, really government organized. Others are much more fee-for-service, and there's a lot of different providers, many of whom are private and in business for themselves, like Switzerland. But every other country has some mechanism of price setting some kind of ceiling for what can be charged, not just for hospital services and doctors, but also for medications. We are the only country that doesn't do some kind of national drug negotiation. As a hospital president, how do you feel about the prospect of having some kind of price regulation?
I'll probably slip and reveal my political leanings, but I'm in favor of price regulation in healthcare. We used to have price regulation. New York State was regulated up until the late 1980s, and there was a system where the prices were almost set the way they are with utilities, and hospitals were never really making as much money, nor were they losing as much money. That process ended with this notion that if we allow the free market to just run rampant in healthcare, we will end up with lower costs. It hasn't worked in healthcare. Hasn't worked for a lot of reasons. Monopolistic pressures with both insurers and healthcare providers. And frankly, the people that are paying the bills, aren't involved in the negotiations. So the notion that consumers are going to negotiate a price, I think, is ineffective. I don't think that's going to work in healthcare.
Yeah. Is this now, can people hear me better? Yeah, and just so everyone knows, the way it works in a place like Switzerland, which is a free market, or a free market in a sense, is there's a ceiling, and hospitals and providers can set their rates beneath that. So it's not like it's, you know, a fixed price for everything, as it is in some countries like Germany, where there is an exact price set. Yeah, and what about this idea of being better consumers of healthcare? I mean, we all say we want to do it, and we're told constantly we should be doing it, but if you say to a hospital or a provider, and I'm just saying a hospital, it's the same with a physician's office, okay, how much is this going to cost me? You can't get an answer. How can we be consumers in this system?
I think my mic is my mic working? Again, there is this notion that if we educate the consumers, that they will be better consumers of healthcare. I think for the consumer to understand the pricing and set the pricing is going to be very difficult. And I think that there's other issues, frankly, involved. One is, you may walk in with an appendectomy and you may walk into an appendectomy. And you can't really price compare. You may be on different medications than you're on medications. Our bodies react differently. I think that there is a level of specialization and a level of individuality, frankly. And we can't predict if you're going to be, we can roughly predict how many days you'll be in the hospital. But complications and other things that may need to be dealt with are highly individualized. And I think to put the consumer in the role of trying to negotiate a price is, in my own opinion, it's very difficult. I think that that some price setting on a general basis would be probably more effective than trying to ask the consumer when they're lying in bed in pain to try and negotiate a price. I just don't think that's an appropriate approach.
Yeah, and what about package pricing? I know that's been a topic in hospital care. I mean, the woman I interviewed for the pregnancy story, she went to a hospital in New Hampshire where her father-in-law was chief of pediatrics and said, and again, she was insurance, but what could happen before the Affordable Care Act was her insurance turned out didn't cover pregnancy. So she had to go out on her own and price this out. It was an accidental pregnancy, but she wanted it. And the quote she got, she said she just wanted ballpark was anywhere between $5,000 and $50,000. And you know, she was trying, she was a 30-something, trying to do the right thing, intending to pay her bills, and she couldn't get an answer. So what about the idea of a package price? I mean, pregnancy, yes, some people will have difficult ones, some will have easier ones, but I know some hospitals are thinking about, okay, let's say this is an all-in price for a pregnancy, and some people are gonna need a C-section and some people aren't, and we'll kind of adjust our package price accordingly.
Great approach, and something that I wish we could see, and I wish we could actually package not only the hospital fees, but the physician fees, the aftercare fees, and there's actually an experiment underway right now with Medicare around total joint replacement to create a package price. It's one of the most convoluted experiments I've ever seen in my life. And over the next 4 years, we will phase this package pricing in, where we will try and get a sense of what the nursing home fees are, what the doctor fees are, and if the hospitals don't take responsibility for controlling the fees that are being charged by the doctors and the nursing homes, the hospitals are going to be penalized in terms of what they're being paid. I think that the approach is a good one. I think that the execution currently and how it's being implemented is probably going to create more, unfortunately, more bureaucracy over the next couple of years than the goal. But if we had a set price for something like a pregnancy that included everything, I think the system would be actually a lot more straightforward.
And in terms of your relationship with physicians, I think this is something that's changed a lot over the years. When my dad was practicing, he was intensely loyal to his hospital. They were on the same side of everything. I was an employee of a hospital when I worked in medicine. How's the relationship with your physicians? How many are part of the hospital? How many are independent? How are those negotiations?
That's something in our community anywhere that has swung fairly dramatically over the last couple of years. 10 years ago, we had one employed physician working for us as a hospitalist. All of the doctors and all of the other areas are private doctors. Our emergency room doctors are in a private group. The anesthesiologists are a private group. The radiologists are a private group. They all bill separately for their services. Over the last several years, we have added physicians and employed more and more physicians, and approximately 70 providers right now are employed by the hospital. And we are negotiating rates on their behalf now, and we are taking responsibility for their billing. That doesn't mean you get one bill. We're still billing individually for every single one of those doctors. I do think as we can bring doctors and hospitals closer together, frankly, in a more unified economic structure, I think we've got the ability potentially to create one bill and one package price for the services.
And why are we getting separate? I'm a reporter, but I'm often curious about this. You know, I go to a hospital, I know, and then I get, New York Presbyterian Hospital fee, and then a separate fee from New York Presbyterian Physician Services. And sometimes those physicians are not in my insurance network, even though the hospital is. How did that happen?
Very frustrating issue for many people. Our tradition in our country is private practice of medicine. Doctors typically are not employed by the hospital. were typically in a private practice, and in a private practice they billed their fees separately from the hospital. The hospital bills for the facility, the doctor bills for the time that they spend. People often ask me, why am I getting a separate bill from the ER doctor? They're working in your hospital. I don't pay those ER doctors a dime. The only way that they generate revenue is if they bill for the time that they are spending with you. And it's as if we were in a hotel. I'm the hotel and they are the massage therapists or whatever coming in working in the hotel. Most of the doctors in community hospitals, that's been the model, that the doctors are private or billing separately. And so when you come into an emergency room, you're going to see an ER doctor. You're likely going to have an x-ray that's going to be read by a radiologist. Again, private doctor who's going to read that has to get compensated somehow, is going to bill for that interpretation. If you need surgery, you'll see an anesthesiologist. And if you need laboratory testing, a pathologist is going to interpret that and bill it. Every single one of those doctors are earning their bread and butter by billing separately. They're not compensated by the hospital. Is changing a little bit for certain categories of doctors, and some hospitals have moved to an employment model where they're actually employing them. But the hospital still won't get paid for the doctor. The hospital has to bill separately for those services as well. So the structure is not packaged together. There's two different sides of the billing.
And do you see them coming together in the future? Because the single biggest complaint I get is, I went to an in-network hospital, I tried to be a good consumer, and lo and behold, the ER doctor wasn't in my network. And I know there are a lot of hospitals now. Why can't you say to the ER doctors, we're in this network. If you want to work in our hospital, you have to be in this network too, because I know it's not as big a deal in New York, and for those of you who don't know, there's a surprise out-of-network billing law in New York, which is unique in the country, where you can contest those kind of bills. But the single biggest complaint I hear from patients is, I tried to keep my doctors in network, and I was, sideswiped basically by someone who wasn't. And they're coming after me for this bill.
They are, and it's probably the biggest complaint that we're getting from people currently. We do not negotiate together with the managed care companies for doctors who are independent. In fact, we're prohibited from negotiating together unless we employ the doctor and unless they're in a formal relationship with us. So that private practice, I'm not even allowed to share rates with that doctor. I'm not allowed to negotiate on their behalf. So each group is negotiating independently. The hospital, we hear from the community all the time, if we drop out of a health plan, people are worried about that because they're going to be billed out of network. And unfortunately, many of our physician groups are not in the same networks of insurers that we're in. We do try to mandate as part of the participation in the agreement, but frequently they are negotiating separately from us, and if they run into a roadblock with the managed care company, they're unable to get a contract. And frankly, the doctors historically in smaller communities were unsuccessful in negotiating livable rates with the managed care companies. Managed care companies have gotten bigger and bigger and bigger. And if you are negotiating as a solo physician, frankly, you're going to get screwed in terms of the rates that you're going to be provided. And many of them can't afford to live with the rates that many of the managed care companies are paying them, so they've dropped out of network. And out of network means if they see a patient in emergency room or privately, they can charge whatever they want. That's led to some abuses. Some physicians have jacked their fees up much higher than I think is reasonable. Most of them have done it because it's the only way they've found to negotiate, to ensure they get a rate that's acceptable in terms of what they can live off of. And there's a notion that doctors are making fortunes. Some are, and I will tell you that some are. I can tell you that primary care doctors, pediatricians, psychiatrists, Many of the bread and butter physicians that are taking care of you are struggling. They're struggling to keep their offices open. They're struggling to get rates that are acceptable. And frankly, they are lone mom and pop shop trying to negotiate around a behemoth managed care company. And that's why many of them have dropped out of network over the last several years. There's efforts afoot to try and force the doctors to be in the same networks. Medical society is fighting that very, very aggressively because they feel that the doctors just don't have the leverage in many cases to negotiate the rates that they want.
Yeah, and I think one of the saddest stories I've heard as reporting this story was following a family practitioner in the Bronx who's a wonderful doctor on his own or with one other physician, and his best payer is now Medicare. He gets about half the Medicare rate from Cigna, from Aetna, and it's all about now, as Bob was saying, about your negotiating position. Are you powerful? And it's partly behind the consolidation we're seeing, and a result of the consolidation, I mean, now we have 3 or 5 big insurers, and 2 of them are merged. Some of them are merging. We've seen hospital systems merge. Has consolidation passed the point where it's good for patients?
I just want to back up to the story of a physician also. So in Montauk, we had one physician at one point, and he ended up in my office in tears because he made $47,000 one year, couldn't pay his bills. And we ended up hiring him and promising him a salary, and we took him out of network for a while because he was the only doctor, and it was the only clout that we felt that we had to get the rates that we needed in order to keep this guy employed in Montauk. And the community in Montauk was frightened, frankly, if we didn't have a physician there. So those are times when we bring people out of network for that reason. The issue of consolidation, I think, is it's a tough one. And the statistic that I just heard at a conference, in that 10 years we're going to see 200 large healthcare systems in the United States, that's where we're going. And there are factors, including managed care companies are negotiating, consolidating, the hospitals are negotiating, and quite honestly, a lot of what's driving that is negotiating clout and leverage. There are some advantages to coming together as a group. We just can't, as a little hospital, we're merging together with Stony Brook, and I'll be very honest, part of the reason we're doing that is because we expect to get better rates. They do, as a large institution, negotiate more aggressively with the managed care companies than we can on our own. However, we also are looking for access to medical expertise, the residency, teaching programs that we think this community needs. Is it a good thing? I'm not sure. I spent my life in community hospitals. My father was a doc too, a general practitioner upstate New York, and I love the old model of medicine. But I just, I don't think it's in the cards anymore, unfortunately. And I hate to be a defeatist, but I do think that we're at a point where we're just going to continue to see this consolidation.
Now we're opening to questions,
Right.
so
Right.
Just wait a second till
well,
Alice comes with the mic.
oh, okay.
Well, tell us on the other side now, how are the Europeans able to avoid the problems that you confront and explain to us? Why is a hip replacement that much less expensive?
Well,
their doctors have status in the community, or are wealthy, endowed, and so forth. What's the difference?
Yeah, I think one of the things is it's everything, and it's the whole way the system approaches surgery. If you looked at those charts, I know they were flying by pretty quickly. Belgium negotiates implant prices for hips and knees, the prosthesis. That's a huge cost for U.S. hospitals because they're each negotiating individually, and there at the moment are only 4 joint manufacturers in the U.S. who have incredible negotiating power. So you might have seen the joint in Belgium, the implant, costs I think $4,000. In the U.S. it would cost maybe over $25,000. And that's a big cost. Doctor salaries are somewhat less, but not hugely less in Europe. The whole way they practiced, Mike Chopin, he didn't mention, he was in the hospital, it would seem incredibly long by US standards. He was in there for a week and had then, which included, I think, an extra 3 days of rehab. But in the US, we have a lot of outpatient rehab. If you get a hip replacement in the US, you have weeks and weeks of going to a physical therapy center, which can be very, very, very expensive. I've seen some shockingly high PT bills because they're covered by insurance generally. The medical research shows that PT after hip replacement is not terribly useful. It's very useful after knee surgery. So we're driven a lot by every system is driven by the finances, and unless we control in some way with packages or rate setting the finances, we tend to kind of defer to the most expensive way to do things rather than the least. The other thing I would mention, which I was, is that we did a funny, but I don't know, it's a little quiz called "Is this a hospital or a hotel?" If you look at Mike Chopin's hospital in Belgium, it was one of the best in the country, but it looks like a junior high school in the US. You know, it's not fancy. But consumers in the US, we tend to conflate and equate quality with, you know, it makes me a little nuts, and I'm sure you hear this too, when people say, oh, I love that hospital, there's free coffee in the lobby and there's great art. And I'm like, right, and then you wonder why your premiums are going up. Right. I think it's a balancing act.
You know, I'll make probably a very controversial remark, but I think one of the reasons why it's different in Europe is because the government is much more aggressively setting prices and controlling the entire structure. And we have this notion that that's quote-unquote socialized medicine. In the United States, here in the South Fork, 50% of our patients are Medicare patients. The rate is set by the government. The rate's set for the doctors by the government. We don't negotiate the price, and the standards are set by the government. And Medicare is, the bills that Medicare people are getting are pretty standard across the board. And those bills are much less. The bill may be higher, but the actual bill is lower than virtually every single payer. And the government is essentially mandating a price across the board. All of the other payers that are out there, several hundred payers negotiating different prices, or plans that are out there, are paying more than Medicare. And doctors essentially are all participating with Medicare. The system is much more streamlined. Now, we break even if we're lucky with Medicare. If we were Medicare, I couldn't give everybody a private room if we were all Medicare. If we were Medicare, I couldn't provide the food that people want. If we were Medicare, I would struggle to break even. But we'd probably break even. That's about it. So we'd see a system that's a little bit more, and I absolutely agree with you. I think it's the government intervention, but you would see facilities that look a little more tired, and a system that's probably a little more rational in some ways.
What do you think are the barriers for single payer in this country? Mm-hmm. And another question I have is that studies have shown that the Medicare MAP programs, the controlled programs supposedly, and the Medicare, the original Medicare comes out cheaper than some of the MAP programs. Why is that allowed to continue?
Yeah, just for those of you who don't know, the MAP or the Medicare Managed Care plans that were supposed to be higher quality care at lower costs, because then the providers got a fixed fee for taking care of patients, a fixed monthly fee. What research has showed is that that has ended up being more expensive. And the question is that because people are getting more better care, or I think equally likely is that a number of providers, and I'm not talking about present company, have figured out how to game that system. So under Medicare managed care plans, if you say someone has more diseases, you get a better payment. So there are a lot of these companies now who go do home visits on people on Medicare and say, have you fallen? You know, let me check your blood pressure. Are you not eating well, to raise their Medicare score? So the problem with American medicine is everything can be gamed. And the problem I see is that good guys trying not to game the system, or the doctors we like, the hospitals we want, aren't the ones necessarily that succeed. It's the gamers who get away with it until Medicare kind of says, "Ooh, can't do that." They tamp down on that, and then it pops up. The problem pops up somewhere else. So it's a really big issue in terms of single payer. And I'll let you know, I think there's been a kind of bugaboo about single payer in this country for a long time. Both of the Democratic candidates have said they would be open to the idea of progressively lowering the Medicare age. That, I think, as Bob said, healthcare wouldn't look the same. And so part of it is, if we want to go that route, and I'm, as a reporter, officially agnostic, it's certainly possible, and it's pretty easy to do in terms of the logistics, but patients will have to change their expectations in a way, too, that you may have to wait. Look, my daughter lives in Copenhagen, and she called in a tizzy. She's 23, and her skin was bad, and in Copenhagen, they said you have to wait until August for an appointment with a dermatologist. That's not what Americans are used to. They're used to, my skin's bad, I want to see someone tomorrow. So I think patients have to change too, if that's the route we go.
There's a lot of barriers, I think, to the single payer, although it's frustrating because we have single payer for many categories of the population. People over 65 qualify for Medicare. That's a single payer. Veterans have a single payer. People on Medicaid, lower income. It's working age people who are dealing with many of these issues. And yet we talk about, we're afraid of the single payer. And I think it's everybody's fault. It's hospitals, it's doctors who are taking advantage of the system. I think it's the managed care companies. Medicare, the statistic is that Medicare, the overhead for Medicare, the bureaucracy associated with running Medicare, eats up about 3 cents on the dollar. Right. Managed care companies were trying to make sure they don't take more than 15 cents on the dollar. Right. And yet they are making fortunes, some of the fastest growing stocks, and a lot of people are holding those stocks and getting rich on those stocks. And I think the question we have to ask, are we really willing to battle that? One of the questions that gets talked about, were we to switch to Medicare, what are we going to do with all the people working for the managed care companies? Huge amounts of people working for the managed care companies. Where are they going to work?
And I think when you asked about why the European countries can do it so much cheaper, when you think of the endless negotiations, hundreds of insurers negotiating with thousands of hospitals and tens of thousands of providers, it's an incredibly inefficient system. And all of that cost and all of those jobs get built in, are now built in to our price structure. So,
and I hear from many people, it's interesting, the comment about the consumer. I think the consumers are an issue. Even Medicare people. Medicare is a perfectly good plan. In most countries, people would say Medicare is a great plan. And how many of you who have Medicare are buying something else because you want that extra thing? Medicare doesn't pay, or Medicare is going to make you wait longer and for certain services. It's providing a fairly consistent level of care across the board. In many countries in Europe, that's what you're getting. You're getting a Medicare type of service. You're not getting all of the extras that we seem to demand. So I think there is a consumer issue in this as well.
I'm curious to know that you joined with Stony Brook. Now, in New York State, there are many other hospitals that are similar to you in Stony Brook. Why do you not form a cooperative as Ace Hardware or IGA, and then you would have the power to negotiate with both the insurance companies and the drug companies?
The Federal Trade Commission prohibits that. We are only allowed to negotiate with an entity with whom we've got a shared governance, we're merged, or we have an integrated quality structure where we're actually managing it from the perspective of quality. Legally, I cannot compare rates with any other hospital unless I'm actually formally part of it, and that's a federal requirement, because the feeling is if we allow the hospitals to do that, they will band together, they will become monopolistic and drive up the prices. And that probably would happen, to be honest with you. So.
That is
cooperative, you would have the power.
The cooperatives aren't allowed from that. There's only two ways that hospitals can get together and negotiate prices. Yeah.
Hi, I am a practicing physician now for 40 years, and I've been managing an emergency department in New York City. 6 days left.
Good for you. I want to be you.
Yeah. I just want to add a few things and point out a few things. That the medical education today is very much into spending, doing things, procedures. I see it all the time. You walk in with a headache, the next thing you get is an MRI. There's very little time for talking to the patient. You get billed by how many patients you see an hour. Right. People in private practice also now are squeezed. They have very little time to talk to patients, and they have to move, as we say, move the room, we call it. This is a great reason, a very important reason why the costs are high, because all those new technology, which wasn't around when I started practicing medicine, is very expensive. So I think this is something that our medical schools are really not focusing on. And you know, at the end of the month, we all get some sort of a summary of how much money we brought in, and we get compared to other doctors. And the emphasis by hospital administration is to do more tests, more procedures, and just bring in more money. So this is a important thing that we have to change somehow, probably starting in medical schools. The other things is that wasn't discussed at all is the cost of malpractice. Not necessarily the cost of the premium, but what is causing us is to do a lot of extra work and tests, even though most of the studies show that this really does not reduce the cases of lawsuits, but that's what's going on. I mean, there's a huge cost to medical care caused by this fear, and all those extra tests that are being done. And I mean, I see here what I call, I see what's called the perfect storm, which is on the one hand, the cost of all the procedures is going up, and the cost for the hospitals is going up as well. And at the same time, reimbursement by the government and private practice coming down. So what is someone like you to do? You're stuck. So I have no answer, and I really, my concern is I wonder, how do you see the future?
My own personal opinion is the system, we are stuck, and I think we're in this, what we're doing today I don't think is sustainable. I really don't think what we're doing today is sustainable. Healthcare is eating up, I think it's 18–19% of the gross national product at this point. That's not sustainable. I don't think our results are that much better than they are in other parts of the world that warrant that cost. And I think that the payment structure is a lot of what's driving it, quite frankly. And the incentives are not aligned with where we should be. We are paid fee for service. We're paid for every procedure and every test. And where we've tried to consolidate that and take away that incentive, we've seen some benefit. There was a time when testing was escalating even faster than it is now. I think that there has to be fundamental change, and I think we're at this period at some point in the future, and we're moving that way, and I think the government in many ways is driving it for global payment structures. Population-based health is another part of it we haven't even spoken about, where providers, physicians, and hospitals and other groups are rewarded for keeping people healthy rather than taking care of their illness. And I'm actually optimistic that some of these things will happen and will start to turn around what we're seeing today. What we're doing today is ludicrous. I'm not going to make any excuses for it. So.
And when you talk about the malpractice issue, it's true, you know, it's not really the cost of the insurance, it's the worry, and how much of that encourages over-testing is a little hard to say exactly. But I'll also say that when you look at the lawsuits and what happens with those malpractice lawsuits, it's not the patients who end up getting the money at the end of it. But I mean, occasionally there are these big payouts, and those get a lot of press, but more often the research shows that people who did suffer from some kind of injury in the hospital don't get reimbursed or compensated. And more importantly, I mean, I have a woman who had a failed hip implant. You know, that happens. It was one of the metal-on-metal implants. She is part of a lawsuit, which is, you know, it's fine, except it's 5 years out now or 4 years out. She hasn't seen a penny of that. You know, it goes to the lawyers, it goes to Broadspire or whatever it's called, the claims processors, and eventually maybe she'll, but in the meantime, she's paying to have her defective hip monitored. So, you know, that is another part of our system that's incredibly complex and makes no sense and certainly isn't good for patients.
I teach a class at Columbia, the public health school, every year. One of my students a couple of years ago was a cardiac surgeon in Canada, in Vancouver, and I asked him, an interventional cardiologist, not a cardiac surgeon, pretty specialized high-risk area, and I asked him about malpractice. He pays $5,000 a year for his malpractice. Our interventional cardiologist would be thrilled with that. And I asked him how they were able to do that. And he said, Canada, they do a couple things differently. Number one is, if you sue, you have to pay the cost. You pay the lawyer right from the beginning. None of this, you know, what we do here. So it's basically no risk to sue. And if you go to court, you have to stay in court. You can't settle. You have to take it all the way through. And that makes people think a lot about whether or not they're going to sue. That's a change that would significantly lower costs, I believe. But again, that's a societal change that has to happen. Sometimes we blame all of the extra costs on malpractice. I think that is overblown, honestly, but there is certainly an element associated with malpractice costs.
I think we have
This
time for one more.
is going to be our
Is
last
that-
question.
is that- yeah, sorry everyone. I could talk
You
forever.
may have answered this question already, but I will pose it perhaps differently. Do either of you think that single payer is doable? And if so, could hospitals exist with it? Could doctors exist with it? And would people go into the practice of medicine as 20-year-olds going into medical school if single payer were the way that they'd get paid?
I would say absolutely, in the sense of, one of the things I've seen in the last 5 years is more and more physicians saying to me, I am so fed up with this system and what a hassle it is and the amount of time I spend on negotiating, that do a single payer. And single payer doesn't mean rates are imposed on you. In many countries, the rates are set with negotiations by doctors groups, government, healthcare experts. So, you know, I think it's possible. I don't think it's the only solution, but I think, and you have to remember, you know, we have this narrative about doctors getting fed up and leaving medicine, and it's certainly true of doctors in my generation who expected to move into a very different kind of practice world. We expected to be independent, and that was a big value. You know, my kids are in their early 20s. Their friends, some of their friends are dying to go to medical school. They get rejected, they go back again, you know. I think there will always be plenty of people who are interested in going into medicine, and they'll be great, but it may not be the exact same cohort as was in my world.
I completely agree. I think that single payer system is, and as I said, we already have single payer for certain groups of population. And were we to adopt that, I believe physicians would join also. I meet many young physicians who are recruiting, and they're looking for a salary, they're looking for a job, and They really don't like this fee-for-service where they go out and have to work all day and then spend all night trying to figure out how to bill. And I think many of them would settle for a salary that might not be as exorbitant as in the old days of medicine. Very few doctors are making that kind of money anymore anyway, and the price they're paying in order to do it is very high. And I think that we'd see some changes. I think the hospitals might not be quite as shiny and luxurious, but ultimately, what do we want? Fancy lobbies or good health care, and I think that's where we need to decide to go. But I think it's doable.
I would love to see, you know, some kind of better national surveys about what doctors think, young doctors think, because there's a lot of kind of propaganda on both sides about they'll never do it, you know, everyone wants it, and you know, I think it's going to be hard to kind of flip a switch and say that's what we're doing, right. But over time, you know, is it better to have 200 or in any one city 2 huge health systems that decide what your care is like with, or a single payer? I don't know. I mean, and I think there are a lot of options, but we're doing none of them now, which is the problem.
Right.
Good luck. Thank you.